Okay. From what I can see, it looks like we are all good to go and live. Welcome to everyone. I'm so glad we could all get together for just a quick rapid fire round of practice questions. Nothing fancy going on here today, right? I just kind of figured one of my favorite things to do is to get together and run through some practice questions because truly practice makes perfect, right? There are only so many ways that the NCLEX can actually ask you a question when it comes time for your exam. So it is so important for us to really get down to business and practice together. So the more we can do, the better. And hopefully we can just spend a few minutes together kind of breaking down some strategies. Like I said, it's like nothing really that fancy. It's not like I have a super snazzy presentation prepared, but hey, if you've got a quick 30 minutes, I've got a quick 30 minutes, we'll do a little bit of practice together and hopefully it benefits you. It's one of my favorite things to do. You ask me some questions, I'll answer them right back in real time. And you know what? If you got anything you want me to answer or something that's, on your mind, kind of let me know and hopefully we can work through it together. So I'm going to kind of start off. I'm just going to kick it off with a question for you guys. I'm going to read it out for you. Let me know what you think about it. If you want to kind of put your answer in the questions, or if you want to just, do it in your own head, jot it down on a piece of paper, whatever works for you. And then I'm going to go through for you exactly how I would work through the question, kind of go through my testing strategies, all that good stuff. And we can kind of see how we would work through it. You ask me your questions as we go, and we'll just have a good little quick session together, okay? So first thing we're going to do, we are going to do a question on oncology, okay? We've got a nurse caring for a client receiving chemo. So remember, first thing I want to say here, you are not going to be administering chemotherapy as a new grad nurse on the NCLEX, okay? That's above your scope of practice. But you might care for a nurse who is administering, or you might care for a client, who has received chemotherapy. Okay. So it's still important that you know a little bit about it. Okay. Do I expect you to be an expert? Absolutely not. But do I expect you to know a little bit so that you can care for them? Yeah, you got to know a little bit. So that's kind of what this question shows you. This client is receiving chemotherapy for multiple myeloma, and they report increased fatigue. Okay, so they're having more trouble completing their ADLs, their activities of daily living. They are just super wiped out. So which of the following activities should the nurse perform? Okay, this is just a simple standard NCLEX question. I'm going to give you 4 options here. Okay, option A, we are going to get labs to assess for hyperthyroidism. Option B, let's place a surgical mask on the client. C, get some blood cultures. Or D, should we review their most recent H&H? That stands for hemoglobin and hematocrit. Hemoglobin and hematocrit. So go through that again. We've got most recent labs for hyperthyroidism, place a mask on the client, get some blood cultures, or should we review their H&H, their hemoglobin and hematocrit? If you want to let me know what you're thinking over there in the chat, feel free to do so. If you want to just jot it down on a piece of paper, you can go for that too. Whatever you want to do to kind of participate in this section. Think through for maybe about 30 seconds or so, and I'll kind of walk you through what I do in my head as far as testing strategies go, so we can kind of go through it together. Okay. Awesome. Okay. Yeah, some of you getting it here. Super good. Okay. So whenever you have one of these questions where it's got multiple different actions, my testing strategy is to think about what the action does, what kind of the implication of the action is. So when I'm looking at assessing a client for hyperthyroidism, right, that has to do with their energy level. Thyroid hormone, we're thinking about, either hypothyroidism, Graves' disease, and that thyroid hormone has to do with how much energy they have. Thyroid hormone is like that gas in the car, right? It makes you go. So you've got lots of thyroid hormone, you've got lots of energy. You don't have a lot of thyroid hormone, you don't have a lot of energy. This client is fatigued. So would I be worried about them having hyperthyroidism? What do you guys think? Like thumbs up, thumbs down? I'm thinking thumbs down. Nay. Yeah, we're not really worried about them not having a lot of energy. It's kind of the opposite situation going on. They're fatigued. So A, eliminated. Now, what about surgical mask? Okay, what does that action implicate? That tells me, well, they've got some sort of infectious process. We've got either a worry that they're transmitting an infection or a worry that they're immunocompromised. This client has cancer, so absolutely, I might be worried about their immune system. But look at the stem of the question. The pertinent part of it is that we're worried about them being fatigued. So, does that have anything to do with putting on a mask? No. That's not going to be relevant. So again, eliminate B. And then, you know what? Blood cultures actually kind of go with that. What do blood cultures look for? Bacteria in the blood. And again, fatigue. You know what? I'm not looking for infection right now. Now, you probably have already deduced that D is going to be our right answer. Okay. So why is the H&H, the hemoglobin and hematocrit, so important? Well, hemoglobin, that's that protein in the red blood cells that carries that oxygen. And that oxygen brings that vital nutrient to our tissues, okay? Without it, our body does not have energy and we get super, super fatigued. So the first thing I think about when my client tells me that they're really fatigued is if they're anemic, if we have a really low hemoglobin and or hematocrit. So absolutely check their H&H. You know what? That goes for if this client has cancer or if they don't. When I hear fatigue, I definitely worry about my client being anemic. So this question, answer choice D, hemoglobin and hematocrit being low, absolutely the right choice. Okay, awesome job. Rapid fire, let's go to the next question. Let me read out this next one I've got here, a cardiac situation for you guys. I don't know about you. Cardiac was always pretty challenging for me in nursing school. I got a lot of it on the NCLEX, so let's practice it. We've got a client with third-degree heart block, and they are hypotensive. The nurse should take which action? Okay, I'm going to give you 4 actions. I want you to let me know which action they should take. Prepare for pacing, obtain a prescription for esmolol, begin chest compressions, or instruct them to perform a Valsalva maneuver. Okay, what are you going to do if they're in third-degree heart block and they're hypotensive? What's the right action in that type of heart block? You've got to know your heart blocks. For me, this is the hardest type of rhythms to kind of figure out and know what's going on. There's like so many heart blocks, but you've got to know it. And if there's a heart block that you've got to know, it's third degree. So what do? Transcutaneous pacing, that's option A. Option B is an esmolol infusion. Option C is chest compressions. And option D is a Valsalva maneuver. So let's think through this. In third degree, that atria and ventricle, they're not talking to each other anymore. They've completely disassociated. We like to say they've gotten a divorce, okay? The atria are doing their thing, the ventricles are doing their thing, and they're just, they're not discussing the situation. So perfusion is severely compromised, and this creates a big problem for our client because they're not getting enough blood out to the rest of their body. And anytime perfusion is compromised, we need to step in and do something about it. Is Esmolol going to help? No, that's a beta blocker, LOL. That's going to slow the heart rate down. In fact, that would probably deteriorate the client even further. So definitely don't give them a beta blocker. What about chest compressions? I mean, we're not quite there yet. D, go ahead and give them a Valsalva. That's going to also slow their heart rate. That's what we do when we need to kind of reboot the heart when we're in SVT. What would be best is A, preparing them for pacing. Third degree heart block, the best answer here is to pace the client's heart because the electricity in their heart, you guys, it's just not working anymore. The atria, they are not talking to the ventricles. And because they're not synchronized, they are not sending out electricity at the appropriate time. And that heart is not contracting and getting blood out to the body. It's a disaster. That perfusion is going in the toilet, and that client is going to decompensate. So 100% in third degree heart block, it's a potentially fatal rhythm. You have to know it and be able to recognize it for the NCLEX. You need to pace your clients, okay? So it's a hard one to learn. I definitely had a lot of struggles with this in nursing school. I feel like the heart blocks were just a really big challenge. And I still to this day kind of use that little like poem memory trick to remember my heart blocks. But third degree is when the atria and the ventricles disagree. They have gotten divorced, and we have to use pacing. We have to pace our clients. All right, rapid fire, time for our next NCLEX question. We're going to the ED, okay? You guys are emergency department nurses, and you've got a hypertensive client. They're in a hypertensive emergency. So what medication can you give them? All right, I've got 4 meds that you can possibly give them. Do you want to do dobutamine, digoxin, nicardipine, or amiodarone? Dobutamine, digoxin, nicardipine, or amiodarone for a hypertensive crisis. Remember, a hypertensive crisis is going to be anything greater than 180 over 120. This is when your client's blood pressure is sky high, and we have got to get it down very, very quickly. Otherwise, it can really, really cause damage. So which of those medications can get that client's blood pressure down quickly? Nice. Yeah, Julia on TikTok, you got it. Amazing. All right. Yes. Nicardipine. You guys, nicardipine is an important med to know. It's a calcium channel blocker, and it's going to help relax those blood vessel walls so that they can get a little bit bigger. They can get a little relaxed, and therefore that blood pressure can go down. So I have definitely seen nicardipine, amlodipine. If it ends in pine, P-I-N-E, we've got a calcium channel blocker. And I've seen those used a lot intravenously in the hypertensive crises to get a blood pressure down quickly, okay? Now, those other medications that I threw out there at you, I threw a lot out you very fast. I know, this is lightning round. We're being crazy today. Is dobutamine. That's going to increase blood pressure. That's a vasoconstrictor. That's actually making your blood vessels smaller so that your blood pressure goes up. So I might give dobutamine if my client's in shock and their blood pressure is like 60 over 30. And I'm like, oh my gosh, they're going to die. We got to get that blood pressure up really fast. Digoxin, that's kind of a special little med there. We could talk for, the next 15 minutes about digoxin, but you don't want me to do that. Digoxin is going to slow the heart rate and cause the blood vessels to dilate a little bit, okay? So it's going to make the workload on the heart a little bit easier. We give digoxin most commonly in heart failure, okay? And then we've got amiodarone, which is an antiarrhythmic. That's going to help when our heart is in some sort of crazy arrhythmias, and we need to keep it beating in normal sinus rhythm. So dobutamine, digoxin, amiodarone, these are all cardiac meds. So any of them were they could have kind of sounded right to you guys. I bet this was kind of challenging, but the only one that lowered your client's blood pressure was nicardipine. So remember those calcium channel blockers. Those are going to be important, okay? Rapid fire, here's another question. You are now a certified nurse and you're going to a continuing education conference. You're going to have to keep doing that. The learning never ends, okay? Now, this conference is about medication administration and times. This is actually, it might sound kind of silly to you right now on, TikTok, but it's important, okay? So which statement, I'm going to read you a couple things, and I want you to tell me which statement, if made by the nurse, would indicate correct understanding, okay? So here's the first thing I want you to listen to. Proton pump inhibitors, those PPIs like omeprazole, we should give those to the client as soon as they eat breakfast. Okay, that's the first statement. Now, next one. Glucocorticoids should be given on an empty stomach, and that will prevent GI irritation. Okay. Now, option number 3, rapid-acting insulins should be administered about 15 to 10 minutes before your meal. Client gets their meal tray, 10 to 15 minutes, we give them their insulin. Okay, that's a third choice there. And then last choice, we've got levodopa carbidopa, and that should be given with a high protein snack so that it gets absorbed really, really well. Okay, that's a lot of statements. Let's kind of summarize. A, your PPIs, give them with food. B, your glucocorticoids, give them on an empty stomach. C, rapid-acting insulin, give it 10 to 15 minutes before your meal. Or D, levodopa carbidopa, give it with a high protein snack. All right. Now, I intentionally gave you all of this info because all of these points are really important. But tell me, which one of those indicates a correct understanding, okay, about how we really want to time our medications with our clients' food? We all eat all day, right? So if we give our clients medications, which one of those is right? Yes, Pret, Molly, Chai, Kayleen, all of you guys are telling me the right answer is C. Absolutely. That rapid-acting insulin should be given 10 to 15 minutes before the meal. That's absolutely. That's when the peak of that rapid-acting insulin is. And that's when it's going to be at its most active. That's therefore when the client's blood sugar is going to be at its lowest. So we want them eating those carbohydrates so that we don't have that hypoglycemia, right? Because, that's no good. We don't want them to get their insulin, not eat for an hour, and then boom, they've got a really low blood sugar. That's a big problem for us. So if we think about those other statements, all of them are the exact opposite of what we actually want to happen. PPIs, we don't give those to the client as soon as they eat breakfast, right? When do we give PPIs? Somebody tell me down here on TikTok, YouTube, Facebook, when do we give a proton pump inhibitor like omeprazole? We don't give them with a meal, right? We give it before meals, Molly, Daniel, you got it. Yeah, 30 minutes to an hour before so that they actually start working. Otherwise, it's not that it's going to hurt our client, but they're not going to be very effective. They're not going to get that good acid reduction. So it's we might as well not have even given the med. And that's kind of a bummer, right? So don't give them with the meal. Give your PPIs at least 30 minutes. I like to give them an hour before my clients are actually eating. Now, glucocorticoids, we actually do want to give with the meal because they kind of upset the belly. They don't feel very good. So if we give them on an empty stomach, it's going to irritate it even more, okay? And that's just not very nice. I mean, it might happen sometimes, but really the ideal is that you give them with your client's food so it doesn't feel so bad. And then the levodopa carbidopa, this is a little bit particular, but what we recommend is that they eat that higher protein food later in the day because it actually stops them from absorbing the medication. So we're gonna have them eat that lower protein meal and have them take that medication, not with a high protein meal like that answer choice said. Otherwise, they might not be able to absorb that levodopa carbidopa. Parkinsonian symptoms like the tremors, the bradykinesia is going to be a lot worse. So all those other answer choices we talked about, they're kind of the opposite. Okay, you guys got that one. You're on top of it. I know all that stuff seems really nitpicky, kind of, in the weeds, but I can guarantee you're going to see something kind of like that on your NCLEX. So it really is important that you know it. Okay, rapid fire. Next NCLEX question here. We're going to go to my favorite. We're going to talk pediatrics. Even better, it's a baby. We've got a 9-month-old infant. Okay, so what's an expected age-related finding? I'm going to tell you 5 age-related findings, and you guys know all of the findings that you would expect. This is a select all that apply. Tell me all the expected age-related findings. So the first one, would a 9-month-old be able to sit without support? What do we think? We'll go through them one at a time. Sit without support. 9-month-old. Can they sit? Yes. 9-month-olds can absolutely sit without support. Molly, Julia, Kayleen. Yes. Yes, Kayleen. Yes, absolutely. At 9 months old, they should be able to sit without support. This is a milestone that I would expect a baby to meet 6 months. So if I have a 9-month-old come in, they're not sitting, they're behind. Now, B, would I expect a 9-month-old to be rolling over? What do we think? Ash says yes. Moana says yes. Sammy, Ro, Kayleen, everyone says yes, and you are right. Now, this is a little tricky because we do have 2 ways that we can roll: front to back to front. Front to back happens first at 4 months, and back to front happens second at 6 months. A 9-month-old should be able to roll both ways. So if they come in for their well child check and mom's like, yo, they're not rolling over at all, again, they are delayed. I might want to put in a referral for physical therapy, early intervention, and figure out what's going on. Okay, next. Option number C, should that 9-month-old be standing without support? They're just standing there hanging out. Sammy says, no, not yet. Julia's like, nah. Ashley says, no. I agree with you guys. Now, they might be pulling to stand and holding on to furniture, but this answer choice specifically says standing without support. And that's not going to be happening yet, okay? Now, I say it's not going to be happening yet. Every baby is different, and some babies do things earlier than others, but this is not an expected finding. They wouldn't be late if they weren't standing yet. So my next answer choice should be very obvious. D says taking their first steps. Should they be taking their first steps yet? Well, if they can't stand yet, they shouldn't be taking their first steps yet. And then going along with that, the next answer choice, E, is walking unsupported. Oh my gosh, if they can't stand or take their first steps, they're not walking unsupported, right? So I've totally given it away, but that's kind of my test taking strategy for these growth and development questions because they're super tricky. And let's be honest, who can actually memorize all of these growth and development milestones? There's way too many of them. I'm a pediatric nurse practitioner and I don't have all of these things memorized in my head. It's like, blah. But you can be kind of logical and put them in order, right? You roll over before you sit, and then you sit before you stand. And then you take your first steps before you're walking unsupported. So if you kind of memorize those major keystone milestones and know kind of when they happen, the big ones are at like 3, 6, 9, and 12 months. Like pay attention to those. and then just be logical, put them kind of in order, and these questions will be a whole lot easier. That's my advice to you about growth and development. Because I know, oh my gosh, even if you absolutely love kids and love growth and development, this stuff gets super, super crazy. Okay, rapid fire. Here is our last question of the 30 minutes. We are going to do a cardiac for pediatrics specifically. We've got a pediatric kiddo with tetralogy of Fallot. Now, you're a nurse who is actually reviewing tetralogy of Fallot with nursing students, and you ask them about what this defect looks like. So, which statement would indicate effective teaching if the student identifies these defects as part of the disorder? We know that tet means 4, so there are 4 different defects as part of tetralogy of Fallot. You've got to know the 4 different parts. This tetralogy is one of the most common ones that comes up on the NCLEX. So if the student identifies VSD, does that indicate understanding of tetralogy of Fallot? Does the tet baby have a VSD? Yeah, they sure do. They do have a VSD, 100%. Now, what about B, an overriding aorta? Does a baby with tet have an overriding aorta? Yes, 100%. That aorta, normally an aorta, right, of course, goes over the left ventricle, right? And it's going to pick up that oxygenated blood and bring it out to the body. But I mean, if it's just going over that VSD, then it's going to be picking up some of the deoxygenated blood. So that's kind of what our problem is in a tetralogy, right? All right, now option number C here. Do they have a pulmonary artery stenosis in tetralogy? Pulmonary artery stenosis. Do we see that in tetralogy? Kayleen says yes. Glam says yes. Ash says yes. Yes, California. Yes, we absolutely have a pulmonary artery stenosis. And who can tell me what that pulmonary artery stenosis leads to? There's one other defect that tight, narrow pulmonary artery leads to. It makes it really hard for the right atria to pump blood out of the right ventricle. So that right ventricle gets bigger and thicker and wider. And what do we call that? There's a technical name for it. Right ventricular. That's right, Sammy. Hypertrophy. Right ventricular hypertrophy. And those are the 4 defects of tetralogy of Fallot. That's that, 100%. You guys, rapid fire, that was a really fun 30 minutes of questions. That went super, super fast. So if you guys have any other quick questions for me, anything you want me to cover specifically in another 30-minute NCLEX rapid fire question session with you guys, I have a lot of fun doing these. I don't know if you guys really liked it or not, but if you want to kind of let me know what you thought of it or any requests or questions, I'm happy to stay on for a second and chat. You let me know. I really appreciate you guys joining. Thank you for being a part of the Archie Review family. It is the greatest joy of my life to be able to share these questions with you, have fun with you guys. Being a nurse is just absolutely one of the best things in the world. It's also one of the hardest things in the world, but I know that when we tackle it together, we can do a better job, right? It's not easy, but it's so worth it, right? So if you have any questions at all, drop them for me. I'll stay on and chat back with you guys for a few minutes. If you want me to do more of these rapid fire 30 minutes of questions, let me know and we will definitely do them. Thank you guys.